Hi, my name is David Rendle. I'm a specialist in equine medicine and I've got a special interest in gastric disease in the horse. I've been asked by Cliffe Equine to give a brief overview of gastric disease. So I was just going to run through how we examine the horse's stomach, what the risk factors are for gastric disease, how we can prevent it, and also give a brief indication of what we can do to treat it. So the horse's stomach is on the left side of its chest and abdomen. Part of it sits behind the lungs, so we can't see it externally with an ultrasound scanner. Part of it sits in the abdomen, but behind the lungs, so we can see the wall of the stomach with an ultrasound machine, but we can't actually see the lining of the stomach. The only way we can see inside the stomach and see whether horses have got gastric ulcers is by passing a camera down into the stomach itself. So when we look at the stomach with a camera, we talk about two different areas of the stomach and we talk about two different types of disease. We used to talk about all gastric lining diseases as being equine gastric ulcer syndrome. We don't tend to use that term anymore. We tend to divide all the lesions into either equine squamous gastric disease or equine glandular gastric disease. And the squamous and the glandular terms refer to two different portions of the stomach. The squamous part of the stomach is the top part, the glandular part is the bottom part, and they're actually two different organs, all within the same space within the stomach. It's just the way the horse has evolved that it has two different organs within one. So when we're talking about squamous disease, most of that is a primary problem associated with the way we manage horses. Occasionally we get secondary squamous disease if horses have obstructions in their intestine or their stomach, but that's pretty rare. Glandular gastric disease, the disease of the bottom portion of the stomach, we don't understand very well. We don't grade those lesions, we just describe what they look like and where they are within the stomach. So we talk about different portions of the stomach, the glandular stomach, the cardia, the fundus, the antrum, and the pylorus. You'll often hear the pylorus talked about because that's where we tend to get most of the lesions. And then we just describe the lesions that we see. And what we've come to appreciate recently is that most of these lesions aren't actually ulcers. The term ulcer still gets used quite commonly, but most of these lesions, particularly the glandular ones, aren't actually ulcers. They're more erosions of the superficial lining of the stomach. So we know that there are a number of different risk factors for gastric disease. If we look at the top portion of the stomach for squamous disease, we know that horses kept under certain trainers or certain managers will be more likely to get disease because of the way they're managed. Horses that are kept in an urban location, not really a problem in the UK so much. If horses aren't turned out, they're more likely to get squamous disease. If they don't have contact with other horses, they're at greater risk, and it doesn't really happen. But if they don't have ad lib access to water, they're at higher risk. One study actually interestingly showed that horses that listen to talk radio are at greater risk of squamous disease, so they much prefer to listen to a bit of music. Why is that? Well, if we look at the risk factors for squamous disease, horses are more likely to get disease if they're fed less fibre, and that's because fibre normally produces layers within the stomach which protects the top squamous portion of the stomach. If we don't have those fibrous layers, then we get more mixing of the gastric contents and more highly acidic contents rising up higher in the stomach. If we feed less fibre, we also get less saliva, and saliva is a natural buffer for the acid in the stomach. And if horses are exercising and there's not enough fibre in the stomach, we also get more mixing and splashing of the acid higher up in the stomach, which causes damage. If we feed cereals, that causes more acid production because cereals stimulate the production of gastrin, which stimulates hydrochloric acid production. And if horses are exercising more, we get more exposure of acid to the top portion of the stomach, and we potentially get a reduction in blood flow, which can also cause damage. The glandular portion of the stomach, the risk factors are slightly different, although there are lots of similarities. We seem to see a lot more disease in warm bloods. We don't know whether that's because of the breed itself or because of what warm bloods tend to do and other management factors. Like squamous disease, trainer is a risk factor. More exercise is a risk factor. If they're exercising more than 4 or 5 days a week, they're more likely to get glandular disease. If they're less experienced, certainly within polo and show jumping, they're more likely to get disease. Probably that's related to stress, or that's the theory currently. If they're competing a lot more, they're more likely to get disease. That's certainly been shown to be true for endurance horses and is probably true for other disciplines as well. And we know that those animals that are more prone to stress are more likely to get glandular disease. So we think most of these factors relate to changes in blood supply within the stomach. If horses are stressed, either as a result of psychological stress or physiological stress with exercise, we get movement of blood away from the stomach, and it's more likely we're going to get damage to the stomach lining, the glandular portion. And it's the total amount of exercise that's more important than the intensity of the exercise per se when we're looking at glandular disease. So if we look at how horses used to live before we domesticated them, I think that gives us some insight on why they potentially get gastric disease. In the natural situation, horses would be trickle feeding for most of the day. They'd eat 10 to 12 meals a day. They'd feed for up to 1 to 2 hours. They typically have a few hours off overnight, but the rest of the time they would be constantly trickle feeding. And they'd constantly move just slowly while they're grazing. They'd eat low quality forage, which is high in fibre and low in cereals and starch. They would get virtually no cereals in their diet at all. Compare that to domesticated horses. They typically spend time confined in stables. They have limited access often to pasture grazing. They get fed in boluses, so large amounts a couple of times a day rather than trickle feeding through the day. They often get fed cereals to increase their calorie intake, even though many of them don't need it. And as they train and exercise, obviously that exposes them to a whole load of different changes in their physiology that they wouldn't normally have in the wild state. So as a result, a lot of horses do have ulcers. And if we look at different studies that are being performed looking at different disciplines, we can see that there are different proportions of squamous and glandular disease in different disciplines. But the percentages of horses that have gastric disease is pretty high. So up to say 90% in thoroughbreds that are in racing, down to maybe 11% in one study looking at hacks. But there have been other studies that have looked at pleasure horses and found 48% for squamous disease, 57% for glandular disease. So half our pleasure horses having disease. And even broodmares, the figures are similar. So it's not unreasonable to say that between half and 2/3 of horses have gastric disease. The challenge that we face is knowing which of those cases are clinically relevant, clinically important, affecting the horse's welfare, affecting the horse's performance, and which of those horses that just have mild disease are not actually affected by the presence of gastric lesions. So the only way we can assess these horses, like I've said already, is to look inside the stomach and actually look at the lining. And when we look at the lining, we can differentiate the glandular and the squamous portions. The glandular portion of the stomach is quite dark red, as you can see on the bottom left, and the squamous portion is a pinky colour. And those pictures that are inserted there show what happens when we get gastric disease. You can see that we've got loss of the normal pink lining in that picture on the right as we've got erosion of the superficial mucosa, and in that picture bottom left you can see that we've got reddening of the glandular mucosa. It's already a pinky red colour, but it's accentuated in those areas of inflammation. So this shows a close-up of the glandular mucosa around the pylorus, and the pylorus is the hole out into the small intestine. And you can see some very mild changes here. We wouldn't be too concerned typically, but just shows some mild change with the mucosa, the lining layer, becoming reddened and a little bit swollen. And that can progress, get a little bit more severe, and then potentially we can get these hemorrhagic lesions as well, so these bleeding lesions that form these little inflammatory craters and nodules, so that indicates more severe disease. We also see these fibrinous suppurative lesions where we get this pussy-like yellowy fibrinous lining, as well as some bleeding to the surface layer of the glandular mucosa. If we look at the squamous part of the stomach, the lesions look different. These are your classic gastric ulcers in inverted commas. So you can see in this picture some small areas of what we would formerly have called ulceration. They're raised up. You've got areas of reddening where the surface layer has been lost, and you've got that accentuated yellowing around those lesions where you've got hyperkeratosis of the mucosa. These lesions are slightly different, similar portion of the stomach. You can see they're more superficial, but they're more extensive, and we've got quite extensive loss of the normal squamous lining of the stomach. The reddened area to the bottom right is the glandular portion, and you can see there's a clear line of demarcation, which is called the margo plicatus. But most of that stomach should be nice and light and pink, and you can see all those reddened areas running through it, which are areas of damage. As that damage becomes deeper, we see more extensive changes within the lining of the stomach. You can see these are more severe lesions where we've got craters forming and areas of bleeding as well. And then as they remain around for a long period of time, we can get remodeling of the stomach, and these lesions would be even more chronic. And these changes can occur quite quickly. Lesions will be induced within a period of days, and these chronic lesions may occur within a couple of weeks. They don't necessarily have to be around for a very long time to get this chronic appearance. And then this picture just shows a really nasty stomach where most of the normal lining of the squamous portion of the stomach has been lost. So the whole squamous portion of the stomach is affected. So it's not hard to imagine that some of these horses can be really quite sore, and this can really affect their performance quite dramatically. So what do we do about it when we identify lesions in the stomach? Well, changes in management are fundamental, along with changes in diet. And we ultimately try and suppress acid using a number of different medications potentially within the stomach to allow the stomach to heal and to prevent the damage getting worse. We sometimes use buffering or lining agents to stick to the surface of the stomach to provide some protection, and we sometimes use drugs which we hope stimulate blood flow to allow the lining of the stomach to repair and to reduce the risk of further damage. And we used to treat all horses much the same, but over the last few years we've come to appreciate that different horses with different lesion types need different kinds of treatment, and we tailor treatment to the individual horse depending on the types of lesions they have and depending on their management. And one treatment doesn't necessarily suit all horses anymore. So changes to management and feeding are absolutely imperative. I'm not going to go into all the details of that because I don't have time, but if you've got a horse that's got gastric ulcers, you need to run through all that with your vets and get a defined feeding and management program to reduce the risk of recurrence. Acid suppression is key. Typically we use omeprazole for that. There's an omeprazole paste or a number of forms of omeprazole paste that are licensed and are effective for acid suppression. There are some other treatments that people use alongside that may have some benefits for the treatment of squamous disease. For glandular disease, the approach is slightly different. One of the biggest challenges we face, though, is knowing which horses benefit from treatment. The severity of the lesions gives us some indication of which horses require treatment, but it's not always that reliable. There are some horses that have quite mild-looking lesions that are quite badly affected. There are some horses that have really quite nasty lesions that are not that badly affected. So it can be a bit of a challenge, and we really do need to assess their response to treatment by looking at the stomach again to assess progress. So if we look specifically at the treatment of squamous disease, that top portion of the stomach, we know that suppressing the acid is absolutely key. If we can increase the pH in the stomach and stop acid production or reduce acid production, then additional treatment is rarely required. And for most of these cases, we use the registered omeprazole pastes. We know that 70 to 80% of race horses will heal within 3 weeks using the paste. But we do have to use that paste properly. It needs to be given on an empty stomach. It has to get through the stomach to be able to have an effect. People think that we put it in the stomach and it neutralizes the acid, but it doesn't. It has to get through the stomach into the intestine, absorbed into the bloodstream, and then it has to get carried around the bloodstream to the cells that are producing the acid to actually have an effect. So I think that's where treatment often goes wrong, because owners don't use the paste appropriately on an empty stomach, and it doesn't get absorbed, and it just ends up coming out the back end, which is a pretty tough waste of money, really, because it's not a cheap drug. So we want to make sure that every bit of it that we can gets absorbed. Some horses just don't absorb the drug very well, and some horses aren't very compliant, and in those cases we can sometimes use injectable omeprazole on the cascade. It's not a registered drug, but we're able to use it if other treatments aren't proving effective. The injectable formulation gets higher levels where we need them, and there's no issues with absorption, so it is a more reliable and more effective treatment. Looking specifically at glandular disease, we still focus on acid suppression, even though these aren't primary acid injury cases. We need to suppress the acid, though, to allow the lesions to heal. We know that the omeprazole pastes aren't very effective for glandular disease. The studies that have been done show that only about 25% of horses will actually improve after 4 weeks of treatment. Typically it takes 8 to 12 weeks, and even then we get a low rate of healing. So the last 10 years or so, everyone's been switching to alternative treatments which aren't licensed for use in horses, but in the absence of anything licensed that works, everyone would typically use an alternative. So some people will add in sucralfate to order oral omeprazole to treat the lesions that way. Most of us, I think, find that pretty ineffective. So the other preferred options are misoprostol, which is a drug that helps boost the blood supply and reduces inflammation. And the most widely used drug now for glandular disease is the injectable omeprazole preparation, which is the more potent way of suppressing acid. But different vets have different preferences, and to some extent we can choose different treatments based on different types of lesion. So there isn't a one treatment that fits all. So in conclusion, gastric disease is common. It's hard to know which horses are likely to have gastric disease and which horses are severely affected by it, even when we can look in the stomach. The only way to know what's going on is to look. Different lesions need managing in different ways, and management is absolutely key, going along with different treatment strategies. Squamous disease is more straightforward to treat. We typically give oral omeprazole paste, but it has to be given on an empty stomach. If that's not effective, and if people can't give it on an empty stomach, then we will look to alternatives. Glandular disease is more challenging to treat. There is no treatment that's universally effective, and it's always a difficult condition to treat. Typically, though, most vets will either use injectable omeprazole or misoprostol for treatment. And just to make the point again that treatment's all very well, but we can only give it for a certain period of time, and fundamentally we need to stop these lesions coming back. So the only long-term strategy is to try and find diet and management changes that will work for your horse. So I hope that's helpful as a brief overview. Any questions, then I know your vets at Cliffe will be more than happy to help.